To begin our first session, the chairpersons for the first session are Dr. Sarama Abraham, Dr. Anil Kumar P., Dr. M.M. Thomas. They say minutes saves lives, and our first session truly embodies that spirit.
Trauma care has evolved tremendously. Today's session will highlight the latest advancements and evidence shaping modern trauma resuscitation. I invite Dr. Sara Varghese, Head of Department, Critical Care, MOSC Medical College, Kolancheri. She is a research enthusiast with numerous publications to her credit to guide us through this topic. The chairpersons for the first session are Dr. Sarama Abraham, Dr. Anil Kumar P., Dr. M.M. Thomas.
A warm good morning to all of you. We, the chairpersons, thank the organizers of ISUMMITCon for giving us the opportunity to chair this important section. Trauma is unique in that, in spite of the advancements, the mortality and the morbidity, long-term morbidity is high. And it is usually the younger generation which is affected. So, there are ongoing changes in the management offering long-term survival of these victims, effective survival of these victims. Let us listen to the experts. Over to you, Dr. Sarah.
Thank you, Madam. As always, it is a very proud privilege to be part of ISUMMITCon. I thank the organizers, Dr. Sam Philip, Dr. Rakhi, and Dr. Manjeet for giving me this podium. The topic that I am dealing with today is damage control resuscitation. And I will be dealing with the topic under these headings. The WHO published a global injury register in July 2024, and it tells us that around 8% of all annual deaths is due to trauma. And 1 in 3 among them is due to road traffic accident. And this is in addition to the tens of millions of people coming with non-fatal injuries in road traffic accidents. We know that trauma has a tri-modal death pattern, and now we've almost moved on to the quadrimodal death. And hemorrhagic shock is the leading preventable cause of death in trauma. And this is what we try our interventions at in the early first few hours. Massive hemorrhage leads to the lethal triad of trauma. That means hypothermia because of exposure and because of the body's inability to respond to the low temperature. Hypovolemia leads to lactic acidosis. All this worsens coagulopathy, and this is a vicious cycle. One augments the other, and if we don't treat it at the right time, it manifests as the trauma diamond of death, where hypocalcemia also comes into play, leading to cardiac arrhythmias and further morbidity. The prime culprit, as we say, is the trauma-induced coagulopathy. It has 2 components. The acute traumatic coagulopathy, which starts even at less than 30 minutes, immediately after trauma occurs, even before we have started resuscitation. This is due to tissue injury, endotheliopathy, which activates the protein C and causes coagulopathy. Then comes the resuscitation-induced coagulopathy because of excessive crystalloid infusion, acidemia, and hypothermia. And all this leads to trauma-induced coagulopathy, which worsens the mortality and length of ICU stay in these patients. So how do we manage it? Damage control surgery, resuscitation, is an approach to major exsanguinating trauma to decrease mortality and morbidity. The term damage control was first used by the US Navy in World War I, where if their ships were attacked at sea, what they did was immediate damage control repair of the ship so that they can reach land safely. They did not do definitive repair. This concept was used in trauma in the 1980s, where only the immediate life-threatening injuries were addressed and patients who had earlier died started surviving. So these are a set of structured interventions that must be started at the site of injury. The aims are to restore homeostasis, to prevent hypoxemia of tissue, decrease the oxygen depth, and decrease the coagulopathy. So for that, the basic principles that we use are permissive hypotension, hemostatic resuscitation, and damage control surgery. This is in addition to the primary survey and management that we do, where X is controlling external hemorrhage by packing, pressure, or even tourniquet. The airway is managed appropriately, airway and breathing are managed, and then we come to the circulation. So do all patients need damage control resuscitation? No. This is for patients with massive hemorrhage that can cause death. There are various injury patterns, signs, and lab parameters that we can use, but we should remember that low systolic BP is a delayed manifestation of the hypoperfusion and shock. It is not the first thing, it is not at that time that we should start responding. So can we predict it? We are using surrogates. There are various scoring systems that can predict the need for massive transfusion protocol, like the shock index, the ABC score, which is a bedside score that can be used, and the TASH score, which is quite specific to predict massive transfusion. So these patients, in turn, need the damage control resuscitation. So how do we do it? The first step is hypotensive resuscitation. What does that mean? That means the patient is allowed to remain at a lower systolic pressure so that the clot that has already formed is not dislodged and the patient is not exsanguinated. And this avoids the cyclic over-resuscitation in these patients. The evidence for this started with animal studies and military data. But the first randomized controlled trial was done by Bickel et al. In 1994, where he compared two groups of young patients with penetrating trauma, and they gave them standard care or delayed resuscitation, where crystalloids were started a little later, and they found significant mortality benefit. There were multiple other studies looking at these concepts. The international guidelines now advocate permissive hypotension or hypotensive resuscitation, but they don't give you specific target numbers. The European guidelines say a palpable radial pulse, resuscitate until a palpable radial pulse. The Americans say a systolic BP of 80 to 90 or a mean arterial pressure of 50 to 60. But we should remember that this is mainly applicable in young patients coming with a penetrating trauma. We should avoid, or it is contraindicated, especially in traumatic brain injury and in patients with spine injury, and also in specific conditions like pregnancy and pre-existing hypertension or comorbidities. So what can we, delaying the crystalloids, so what can we give? Then comes the principle of hemostatic resuscitation. We don't bleed normal saline, we bleed blood. So to stop the coagulopathy, we have to replace with blood. This is the concept of hemostatic resuscitation, and early use of blood products is advised. But the availability of whole blood, which is cross-matched, is limited. So we try to reconstitute by giving products in a specific manner. The studies of PROMPT and PROPER, which was done in different centers, level 1 trauma centers in the US, showed that transfusion practice of giving 1:1:1 ratio, that is PRBC, FFP, and platelets, gave maximum benefit in hemostasis as well as mortality. So we transfuse with early blood products, and to ensure that we give a 1:1:1 ratio, which is of maximum benefit, we might have to activate the massive transfusion protocol or make sure that we formulate one in our departments. We reduce crystalloids, and once the patient reaches a higher center, we can even use point-of-care testing like TEG and ROTEM to make sure that our resuscitation is accurate. We should also remember to give the hemostatic adjuncts. CRASH 2 showed us the benefit of tranexamic acid, and it is now proven that tranexamic acid given within 3 hours of injury has the greatest benefit. So the dose of 1 gram IV within 10 minutes of injury, and the next 1 gram over 8 hours is the recommended dose, or even you can give 2 grams IV within the first 3 hours of injury. Anything later than that has increase the thrombogenic potential and should not be used. We talked about hypocalcemia, and replacing calcium is very important. We should give 1 gram of calcium at least after every 4 units of blood products, or we should try to maintain the ionized calcium levels above 1.5 millimole. Fibrinogen concentrate, prothrombin complex concentrate all come in specialized situations. How do we know we are doing okay with the resuscitation? We look at the responders using continuous monitoring of their vitals and even lab parameters, and we can divide these patients into 3 as responders who improve and remain stable, and we can consider definitive management in this subset. There are the partial responders who give us a little more time to investigate further, maybe do a CT scan to identify where the bleeding is coming from, and then go for a definitive management. But the non-responders who remain hypotensive even after our efforts require damage control surgery. That is, they have to be taken into OR, where the aim is for hemorrhage control. The main aim, if there is an intra-abdominal bleed with liver bleed, pack it, close it, and come off. You can try decontamination of wounds with cleaning and of the contaminated area, but nothing further, no definitive repair. So the patient goes from ER to OR for the damage control surgery. Then they are shifted to ICU, where we continue the resuscitation to stabilize the patient and achieve homeostasis and reduce acidosis and coagulopathy. The patient can go for definitive surgery after 48 to 72 hours. The patient, we can stop resuscitation once the patient is well perfused with a palpable pulse and a good capillary refill time. And recent advances are looking at more pre-hospital methods to reduce the trauma-induced damage to the system, which includes ECMO and Ribova even in pre-hospital setting, but these are all under research. What are the controversies that we have to think about? When we talk about hypotensive resuscitation, I don't know how many of you heard, but yesterday Dr. Ramkumar was saying even 15 minutes of hypotension intraoperatively can cause increased morbidity and mortality in patients in the postoperative period. So how are we leaving them with hypotension? Is it applicable only to the younger generation who can tolerate it? Is it generalizable? What is the duration that we should give hypotensive resuscitation? And in the Indian scenario, where the patient reaches ER late because of traffic, because of transit time, is it still advisable? And hemostatic resuscitation, where we avoid crystalloids, is it still holding true? Crystalloids are safe and easily available, and the refill study, which was finished in 2022, compared PRBC plasma transfusion with 0.9% saline, and they found no change in mortality or lactate clearance between the two groups. Should we rethink the strategy of not using crystalloids, or maybe limit ourselves to a slightly smaller volume of crystalloids? So the take-home message is, DCR is a complex process that aims to restore the physiology in order to save the life. Okay, it requires a little bit of flexibility, awareness of the complications, and careful planning and attention to detail. Thank you.
Thank you, Dr. Sarah, for that crisp and insightful update. Patient blood management is not just about transfusion. It is about optimizing hemoglobin, minimizing blood loss, and improving patient outcomes. I invite Dr. Suresh G. Nair, Senior Consultant, Aster MedCity, Ernakulam, a veteran in anesthesiology with more than 2 decades of experience, to take us through this revolutionary approach.